All right. Well, welcome everybody. So my name is Angie Charlotte. You don't have a whole big bio or anything on here from me. You will have my contact information on the back. We're going to talk today about chronic care management and what does it really all mean. I am going to be upfront. I am presenting this slide deck. However, I do want you to know that this slide deck was created by my colleague, Lisa Schlappman, who is our chronic care management subject matter expert. And unfortunately, Lisa is not with us today, so I will be presenting. So anyways, before we get too far into this, the chat box is open. We did put that to remind everybody to mute their lines. And I also put in here, let's see if this chat thing really works. You know, we're always asking questions, wondering, I wonder as we go along in this slide presentation. It's Throwback Thursday. So let's start the chats with a Throwback Thursday thing to make sure that it works for everybody and you can ask questions. And so I put on here, what's that one thing you remember in healthcare that is no longer a good or optimal practice? And for me, you know, again, age on my side. So mine is truly, I remember the physicians smoking at the nurse's station, taking care of patients, going in the patient rooms with their cigarettes. You know, it was very odd and bizarre, but I do remember that. So anyways, I see someone's asking about the slide deck. Jake, are you making that available to everybody so they can have that handy?
Well, we're sending out a recording of the webinar after it all compresses and everything. I can get the file out. It typically takes about an hour. And then Susan, yes, if you'd like the slide deck, I'm happy to send that to you. I don't know if I can send it to like automatically send to everyone. It's a pretty big file. But Susan, yes, if you'd like the slide deck, I'd be happy to send it to you.
Yep. So I know for everybody, there are quite a few slides on here and they have a lot of color. And so to download them, it took a while with all of the stuff on them. So let's get started. So what is CCM, chronic care management? Now, this is kind of that standardized delivery of structured identification of what the patient needs, what the patient lacks, and then we provide those solutions and resources to meet those needs. That truly is the biggest thing that we have. You know, it is all about care coordination, and I will give you some of the Angie versions of this through the entire presentation. And it really is, you know, doing the right things for the patients and for our communities. And that's what we want to do. You know, we want to give them the tools and resources they need to be successful in their own care, you know, and really have some of that autonomy. You know, so we do that and we help to start eliminating some of those care gaps, you know, that the patients may or may not experience, such as patient education, those disease processes. We can tell a patient until we're blue in the face that they have high blood pressure and they're going to nod and say, yes, I do, you know, and they recognize it, give me a pill and I'll go home. But it's really understanding, why do you have high blood pressure? You know, what are the symptoms? What is in your lifestyle that's causing some of this high blood pressure as a potential? You know, and really look at those self-care deficits and how can we improve that at home? You know, early signs and symptoms. I was just at a friend's house last night and her husband had just gotten back into AFib, you know, so it's recognizing those signs and symptoms. What does that feel like? What does it look like? You know, what are my symptoms on the outside that my family may see? And what do I feel on the inside, or some of the stressors that may cause that? You know, medications and why we take them, when we take them, how we take them, with food, without food. You know, how do we assess that and how do we keep track of that? You know, and understanding and reteaching the patients repeatedly. You know, it takes a minimum of 3 times to really learn and comprehend. See one, do one, teach one is a typical phrase we as educators think of, but it's really, you know, understanding and reteaching it just to our patients and our clients, and also to their families if they are present. There's those early interventions to reduce these care gaps. Again, assess during frequent calls. You know, do we have to make several calls at a time? Post-discharge and ER follow-ups, you know, making sure that they are getting into the providers, within 7 to 14 days of discharge. That's our transition care management process. Following up from our ER visits, did they go to their provider? Are they aligned with the provider? Are we looking at any new needs early on? It's a new diagnosis. What can we do? How can we assist? And this could be as simple as understanding how to use crutches for a broken ankle, and you can't have throw rugs on the floor. And it could be for a youth, a teen, a 20-year-old. As we start to look at this, I know chronic care management is for our Medicare patients, but we begin to embed the way we do things in all our populations, and the way we start to see, visualize, assess, and really pull out some of those questions and help filter through some answers for them. We want to avoid those exacerbations. We typically hear this with asthma, CHF, COPD. Even pneumonia can have some exacerbations during that recovery phase. And then having that resource help 24/7. How do they access it? Who do they get? Is it automated? Is it not automated? So as we look at our care coordination process, it's really starting to integrate several components. It's not just about CCM, and enrolling them into a chronic care management program, developing that plan of care, and looking at all those efforts that we do, for billing purposes. It's also care coordination, again, going back to those care gaps and looking at achievable goals for our patients and, our community resources. How do we, get their community resources aligned with them? And then our preventative care. This can be done in our annual well visits, but it's also, done on a routine checkup. They're there for hypertension checkup, getting their meds refilled. But at the same time, we can say, hey, it's flu season. Do you need your influenza vaccine? I see you haven't had your pneumonia vaccine. Should we get that? Would you like to get a mammogram, a colonoscopy? We can ask these questions at any given point in time. Do our falls screening, our smoking cessation. I try to enforce and encourage folks to really look at that and begin to build their preventative care measures as a continuation of care every time. So every patient, every time. So I'm going to ask falls screenings, tobacco screening, depression screening every time the patient is in. Our care transitions, making sure that they get all of their needs met from transition to each care entity, from the ER to the provider office to home, and making sure that they have everything that they need, making sure they can fill their medications. If they are in a skilled bed, swing bed, making sure that they have all those transitions very smooth. Home health is another one, or DME services. And then we could start to see some of the patient impact as we start to build the entire care management program. And these things that, we don't always see an ROI on this. And there's another slide that's going to be very similar on this later in the presentation. It's really looking at, what the patient achieves. And that's really what we want to do, is to help them feel empowered. We want them to be compliant in their own treatment and understand how they need to improve in their own self-care. I can't eat McDonald's French fries every day anymore with the good old boys in the Farmers Club. I need to modify a little bit of what I am doing. We also allow them to have that little bit of extra attention. They get 20 minutes, per month in CCM program with undivided attention from a provider's assistant, whether it be an RN or an LPN or even a certified medical assistant in some cases. But their satisfaction levels start to rise. And we all know when that happens, they tell one person tells the next, and again, it filters through. And that's what we want to achieve as we continue to move forward. So again, we're looking at, satisfaction. The patients are happier with their care. They're taking some initiatives. We're building that provider-patient relationship. And we're also building that provider-staff satisfaction in that the staff have some autonomy to do some work and assistance with our providers' blessings, I guess you could say, and, continue to assist these patients without having to keep running out and asking the provider, can I do this? Can I do this? It's already built into our systems. We're reducing our per member per month rates, looking at that cost of care. And that, not everything has a bottom line number to it, but it can be associated down the road with a specific number. Reducing our unnecessary testing and treatments, and then really looking at that downstream spend. especially if we start referring to specialty care. If we're doing some specific ordering, how do we share that information so that our patients know, hey, we're on top of it and we're not going to require you to have a second test done of the same thing. So, and then our quality measures, we are all about quality. If you're part of a critical access hospital, there's not a lot of quality reporting right now outside of MBQIP, unless you're part of Joint Commission or a system hospital. But it is coming, and we know this. If you're in an ACO, we know there's some specific quality reporting that is required. And then part of the old myths that we've been doing, reducing our readmissions, our ER rates. This is everywhere. I just came back from Austin, Texas a month ago, driving down there and back to Illinois. And in any of the smaller communities, actually any of the communities I think I went through, you would see the big billboard signs, ER wait time, 5 minutes, 10 minutes, 0 minutes. We're starting to look at that and improve our treatment process and workflow to really enhance that patient experience. And that also is reflected in our improved survey scores, as well as our compliance rates in what we're doing. So what's needed to truly be compliant? So we know that this has transitioned over time. In 16, it was CCM, and then in 17, they started loosening it a little bit. And gave some extra requirements. And then at 18, they restructured, and we started having the 3 codes. The reimbursement rates changed, and they removed a code for the RHCs. And then we started in 2019 with the GO 511. And that's where we're pretty much at today, although the proposed rules do have a few new things in them as well. And so with the GO 511, it's updated, it's added that 4th additional code. Our change in pricing structure has changed, but it really demonstrates that CMS is listening. They're saying, hey, we see this, we know you're doing this, and look at what you're doing moving forward. So there are the 4 bundled codes. The 99491 is the RHC practitioner provided CCM. That's that 30 minutes or more of CCM services. That's the additional code that has now been added for everyone. So, and then we know that there are some specifics to bill for services, for CCM services. And there are some great resources out there. Again, we have those on the left or the right-hand side, but on the left-hand side, it's just kind of that down and dirty. Here you go. You need an initial visit. You need a patient consent. 2 or more chronic conditions, which you can guarantee the majority of our patients are going to have. And if you're kind of struggling, is that a chronic disease or not, you can go to the chronic conditions warehouse and find a lot of that data as well. And then going so forth, and we're going to go through each of these here in just a minute. And then it starts to talk about the reimbursement rates, and that 99490, which is the one we're very familiar with, doesn't work for RHC use. So now we have the GO 511. And then we still have our copays and deductibles are all still applicable. So the patient has 2 or more chronic conditions. This is an expectation. They are expected to last at least 12 months or until death of the patient. So that's, again, like I said, go to the chronic care warehouse if you think you're questioning if it's 2 diseases. There must be an initiating patient visit, a billed E&M visit between the primary care provider and the patient within the last 12 months. That doesn't mean you have to have them come back in to do the consent, because we can do all of that verbally and write it in the patient record. Or even over the phone, through a patient portal. There's multiple ways you can obtain that consent as long as it is documented in the patient record. Whether that initiating patient visit happened to be 10 months ago, 9 months ago, and we didn't really discuss CCM at that time. It doesn't necessarily always take place at the same time, but again, we do need that consent to continue moving forward, and then every 12 months thereafter. Must have a certified EMR. I can't think of anybody that doesn't already have that. Successive routine appointments. Schedule about 3 or more. If it's at all possible, start looking at those successive appointments with the same provider. And then enhanced communication possibilities. Here's where we really start to engage our patients and say, hey, how do you want us to talk to you? Additional access via the bedside telephones or besides the telephones. Is it in our portal, email, text? What do they like? Do we offer secure messaging? What does it look like? Document our education surrounding this, and that this is what was agreed upon in the patient record or in your tracking mechanisms. So if someone else is doing anything with that patient, that they know also how to access their patients. So again, the 24/7 access to care, this is actually a lot easier than you think it would be, because most of them are using an ER nurse to take these calls should we have one. I know this was a real bugaboo when we first started this back in 16. And, you know, a lot of our hospitals were having huge concerns over the 24/7. And they started looking at, okay, what can I do differently? How can I make sure that this is achievable? And they allowed the charge nurse or resource nurse or house supervisor or an ER nurse, you know, that was on during off hours to be able to access the patient records, which is one thing that there is a requirement to have access. And the patients could call and a certain number would ring, or a certain bat phone basically would call and they could pick that up. During normal business hours, it's your care coordinator, care manager, care nurse. And then outside of the normal business hours, they were to address all urgent needs. So our care team, you know, typically addresses everything else, and then the emergent would be after hours. And then, you know, patient plan of care and information is accessible for them. The one thing I do want you to know is that we did, when we first started this, we really thought we'd get a lot of phone calls, and we didn't. We might have had 4 in a month's time, and they were non-urgent, emergent calls and did not need to have any guidance or resources at that time. Care plan elements. So again, as we start to build our care plans, what does this look like? You know, what do we need to have as part of our care plan? And this is where, again, we engage our patient. What are your goals? What do you want to do? I want to walk my daughter down the aisle. Well, how far can you walk right now? I can't even walk to my mailbox. You know, what can we do to help encourage small implements of change to get them to their goal success, and at what time frame? And again, we want to make small wins, and we want them to feel accomplished. And we want to celebrate those small wins and then add that next one on top of it. You know, so we start to look at their assessment skills. You know, what is it? Physical, mental, cognitive. You know, again, kind of looking at those whole social determinants of health, you know, their environment, their surroundings. You know, what do they typically fix for meals? You know, that's something that's always nice to know as we start to have those conversations with them, and the encouragement to continue on. You know, our medications and medication management. Do they talk to their local pharmacist, or is it only providers that are giving them the education? How do we know this? What do we know about it? And then who's responsible for each of the elements or interventions if we have multiple ones, and how are we going to achieve that success moving forward? And then we have, you know, that process for transitions in care. What does it really look like? You know, here's your CMS definition, but it's really sharing that information of the continuity of care document, the CCDs. And when we first came out with this, and granted, I was a bedside nurse before this years ago, I don't remember hearing what a CCD was. That was new terminology to me. And that may still, to this day, be new terminology for some of your nursing staff, you know, in understanding what is it that you're asking me. You know, but again, it's really making sure that that patient has a smooth transition from provider to provider, or from provider to home, and then back to provider, and having that ongoing open communication with them in that dialogue of, you know, how to better self-manage. But really, it's to assist in those care gap eliminations, you know, and reduce them down for patient success. And it also helps your providers to talk to each other, especially if we have our specialists talking and providing information. And it should always be timely, you know, and set those goals and expectations moving forward. So with our CCM, we have 20 minutes of non-face-to-face activities per month. You know, what does that look like, and how do we achieve that? And again, it's required to bill on a calendar month, and set up with your billing office how you want to do this, how you want to track it. Do you have timers? You know, what are you doing? There's multiple software systems out there. Some use just a simple Excel spreadsheet when they are tracking, you know, their time. There, again, are multiple ways you can do this. Some might have it built into your EMR system. You know, but clinical staff time counts, you know, and that's really what we want to look at. our data review, everything that we're doing, changing their treatment methodology, leaving them a message, all of that can count. And then the face-to-face time cannot be counted. So if they come in during that month for, say, blood pressure pills or something like that, that is not counted towards their CCM 20 minutes. That is separate. And then activity directly related to their chronic conditions. If they get a new chronic condition, we can always add that time in, and then document and track all those activities, the start, the stop, the summary, any changes we made, any successes, any patient comments, what was their feedback, and where do we go from there. So then we look at, where do we really start? So let's get started. Some tools for success. I cannot say enough about how strong administrative support is essential, throughout this entire process. Looking at your teamwork, participation, accountability, really looking at, your workflow. Who does what? Do you understand who is doing what within the clinic side, the hospital side? How is communication, and patient information transferred from a hospital to clinic, a provider? Again, and then looking at how are we making sure our expectations are met by all staff? Do they understand the expectations of this? And then having that education plan. And it's not the education plan for the patient, it's for the staff. Looking at what do they need to be successful, what tools, what resources, what software, what is it that they need to make sure that they are successful in communicating with their patients, but then also having ongoing development and that, again, patient-provider relationship. And as care coordinators, care managers, we are also, that provider. In essence, we are speaking for our physicians, our nurse practitioners, our PAs, et cetera. And then looking at what kinds of policies and procedures do we have in place, and then enforcing that communication and collaboration with each other. So you need to be ready for change before you ever implement change. And that's not new to us. We kind of know this already, but it is hard. It's hard to make change. And it's hard to change a person's role within a clinic or provider setting. So again, as we start to think about our change, is the staff ready? Have we done any kind of a readiness assessment for change? Done any change management skill sets? Even just trying something new. Don't even start with the CCM process. Look at a small, simple test of change that you can do in your office that is going to be a little bit disruptive, not a lot, but maybe a little bit, and to see how well staff accept it. And then we start to build from there. Our current care coordination foundation is based on change. So we know that we have to have facility and system goals. We know that we have to have those resources and, potentially maybe even some funding available. But really it's to build on that sustainability moving forward and making sure that we don't lose track of this. Once you start it, the patients are going to become expecting you to have this offering. They're going to get so used to having this that it becomes, second nature to all of us as we continue to build it. So, and then we want to assess our providers and staff. How well are they open to this new model of care? What are their current practices that will support it? What kinds of practices do we need to add in? Looking at their workflow, looking at, any proactive or reactive approaches to care that they're currently having. It used to be that the patients would come in and have a very passive role. Whatever the provider said is what they did. Now we're asking them to have a more active role. We're asking the providers to give them choice. Here's your choice of a blood pressure medication. Here's the one I would recommend, but there is another alternative because of the side effects of this one. Again, we want to have that two-way communication and engage our patients as active participants in their care. Your cholesterol is a little high, but your LDL and HDL look really good. Do you want to do something about this? I don't think you need to, but here are some lifestyle modifications to help reduce it down. And then looking at our caregivers, they definitely need to be as part of this mix, and often can be neglected or forgotten about when the patients are sitting back there in a provider office and they're by themselves and their caregivers are still waiting in the waiting room. And then any contracts aligned with the system goals, looking at, who are we contracted with or are we contracted with in our specialty care and specialty services. And then as we move forward, again, develop a plan. It's kind of like the patient care plan. It's the care plan for the clinics, care plan for the hospital. This is what we need to do, our scope. What does it look like? What does short-term success look like? And then what does long-term sustainability success look like? Our concerns and huddles and potential risks. You know, how are we going to address them? Which ones can we address immediately and which ones might take a little bit of time, you know, to make sure that we can meet it. And then identifying our partners, our services, agencies, facilities, you know, again, what strategies are needed to align new partners and how we get them there. And then our resources available, you know, versus what's needed. You know, again, we have to look at our community resources and how we continue to move that bar. You know, does our community offer everything we need in our primary service area? Maybe it's in our secondary service area in a small town next door, you know, or maybe it is in our urban counterparts, tertiary care centers. But again, you have to remember, one person cannot carry the load for everyone. This is a team effort, and it does require everybody participating moving forward. So right from the start, you want to involve your entire team. And this even goes down to sometimes even your housekeepers, but your front staff, front office staff, you know, everybody in between, you know, and then looking at your hospital staff and who you communicate well with or mostly with. So again, care team members, our providers, practitioners, and you can see the list goes on.
Angie, are you there? Stand by, everyone. I think we had a problem with Angie's phone. 1 minute.
I don't know how. How do I get back in?
Angie, you're on. We got you now. We lost you there for a second.
All right. Now I got to go back. I was hitting the buttons. All right. Can you still hear me?
Yep.
Okay. So we're going to involve our staff. We're going to create the tools and forms essential for success. What does that look like? You know, if we're looking at it in the billing components, we definitely want to look at, okay, what do we need for the billers? You know, what kinds of codes? How do we track this? What do they need to move forward? And then identify our benefits, you know, understand the why, you know, but also understand the what's in it for me, for your staff members, so that they can move forward successfully. You know, they really understand and get it, they embrace it, they know they're part of this change and this community benefit as well as individual patient benefits. And then make it easy to participate, you know, outlining clear processes and workflows, identify and share your expectations, you know, really looking at your staff meetings. The one thing I cannot say enough is about huddles and looking at how do we meet those expectations of each patient. And when we do that, we can look at it through the huddle process. So again, who does what? This is something that we continue to need an understanding of. When I did some teaching with Patient-Centered Medical Home, I'll give you a very quick down and dirty way of learning this. And we were talking to the front office staff, how do you guys register a patient? You know, what is it that is required? And we found so many different workarounds that they were doing to be successful. So again, you know, as we look at who does what, we've got somebody that has their phone off of mute.
Guys, please check your phones and mute them, please.
Thank you.
There we go.
And what we found was that the staff had developed workarounds for convenience factors. And it wasn't necessarily in their, job descriptions. It wasn't in their policy and procedure manuals. It's things they just learned. And so some of those may be the best things that they've ever done. And we want to make sure that we continue that, but we also have to update our policies, procedures, and who does what. But it's really looking at, okay, who's going to do what in the chronic care management process, or even the whole gamut of just care coordination, care management program. And, our clinical staff versus our front office staff versus our providers, everybody has a role to play. So we want to look at that and say, here's what I need, this is what I need, and how can I make it successful for the patient in the end? So this just gives you some identification of roles and responsibilities. And then building that collaboration. And this is where, it really is about everybody. And you need a top-down approach of support, to make sure that we continue to do this moving forward. And it takes an army sometimes to get these things accomplished, but it is worth it in the end. And really enhancing that communication pattern between your clinic and hospital. Align our goals, our missions and systems between the clinic and the hospital. Explain how our programs are going to continue to support these goals. What level of delivery are we going to do to make sure that we're continuing to support these missions moving forward? And then remember, our structure improves success. Identify our challenges very early. And, those hurdles, those barriers, those roadblocks, which ones can we fix immediately and which ones might take a little bit of time? Which ones may need some admin support to reduce or eliminate a hurdle? And then how do we gain those efficiencies and effectiveness? If you've not done any lean training, I really encourage you to look at doing some lean training, eliminate your waste and improve the efficiency, avoid unnecessary costs, remove uncertainty and confusion. Well, he's doing that, she's doing that. We want to make this better, organize our approach and standardization, and continue to have, future growth, and sustainment. And how are we going to be successful at that? What does success look like in the eyes of admin, in the eyes of a provider, in the eyes of a patient? We want to make sure that we're capturing all of that information. And then we have, really utilizing that iterative process. And this really is, that repeated cycle. That's what iterative is. It's a repeated cycle, so you get closer and closer to the goal, and during those repetitions and repetitive actions that we're reducing more and more of basically care gaps. We are fixing each essential component to improve over time to eventual successful goals. And, the process really is identification, planning, and implementing. And we go back, we continue to repeat this process as we continue to look at, what is our challenge issue that we're facing today? And, it's fixed, it's not fixed, what can we do about it? And, just keep moving it forward. And then we have some of those innovative programs that, really thinking outside the box. How do we think outside the box? Do we have any kind of nice programs that we can look at? Are there any YouTube videos are great for this, or TED Talks, to have the staff listen to during a break session or during a unit meeting. Really start to be creative in the way we do things. It used to be in the hospital, I would have to ask housekeeping how to change a process on several things because they knew everything. They were kind of like the eyes and ears of the entire hospital because they were everywhere. They knew what was happening in the doctor's lounge or in the third floor back room of the OB department where the staff were having their break rooms and things like that. So again, we want to think outside the box. Who needs to help us with that? Utilize our technology. What technology is there? What's affordable? What can we start putting on our radar in our capital budgets? Our evidence-based research, this is easily accessible. Make sure that it's within the last 3 up to 5 years. And then target some of our social determinant trends. This can come right off your community health needs assessment if you have one. We used to be doing I-plans with our local health department, and that's another area that gives us a nice look at those social determinants, both primary and secondary markets. And sometimes our simple solutions are the best drivers of change and success. And it was just a small process. So you definitely want to make sure that you're staying innovative, on top of things, and talking to staff. It's not just from the top down directives. This is, the people that are doing the work day to day, they have ways of workarounds and successful ways of thinking and doing things, and they just need a venue and a mode to be heard. So again, a care coordination toolkit. There are some best resources out there. This comes right off of one of the CMS innovation sites, and it talks about, obviously ACOs in this one, but it is a very nice toolkit, and you have the PDF link there. I highly encourage everyone to go out there and look at that. And then some hurdles to avoid, from some of our lessons learned. We definitely need to look at, okay, what did we learn from this? And how can we, better prepare moving forward? So some things that we learned early on, not everyone is educated. Not everyone, even in our provider staff, is educated in all of the new changes in healthcare. Just like we went back to our chat box and I asked, what is something we did in healthcare, as a Throwback Thursday question, that is no longer best practice or optimal practice? Not everyone is educated well, or there's poor education and they still have questions. Staff is unsure of the roles. They're not quite sure who's doing what. How do we look at that differently? Our tools weren't identified ahead of time. We didn't know what we didn't know until we started getting into this process, what tools we did or did not have, or what tools we had that just didn't work. And they just didn't work, create that workflow we were looking for. While they look great on paper or on the screen, they just weren't functional. And we have to really kind of create those pretend patients or fake patients to start looking at, do these work, do these not work? We had resources that were unavailable that we thought were available. Looking at our referral process, we were really unsure of how that was taking place. How did we get the communication back? Did we get it back? Did they fall off our radar? Maybe we weren't following up on our referral processes, and really looking at our policies and procedures. And, I know staff are not going to open up the policy and procedure manual, look at how they need to do something, but it's just really starting to embed those practices of what we do, moving forward, that they become very aware of. And we really want to promote that right mentality as we continue to do this. We should want to do this for our patients, for our communities. And what does that look like? The program impact items that we are measured on, all of us collectively, the providers, the staff, the hospitals, the clinics, it's a collective whole. We're all in it to win it. Our revenue is also money saved. What does that look like? Not everything has a dollar amount tied to it directly, but indirectly there is monetary gains in this. And then patients have that right to choose. They're embedded now into their decision making. They're no longer that passive, okay, I'll do whatever you tell me to do. They have that right to choose. And they give us consent to help them along the way. It's no longer forced. It's no longer required. Sign here on the bottom line, because we're going to take your firstborn child. It's truly looking at, hey, we want you to be part of this process. We want to be here with you along the way. Would you please give us consent? And then, one of the things that we definitely did not learn right away was the dilution of what we require our care coordinators to do on a day-to-day basis. This has been probably our biggest hurdle, and it still is today, is that dilution of other duties as assigned. So we have, our staff member that is not 100% devoted to the care coordination and chronic care management TCM practices. They are being pulled to fill those holes. Whether it's in the clinic side or in the hospital side, they're getting relocated and reallocated in different areas. The realization that there's downtime is truly false. We started looking at this early on, and our care coordinators were complaining they just didn't have time. And I'm like, why not? And even as a prior bedside nurse and then moved into management myself, I was like, I don't understand what's happening. But it was really looking at, this is what is required of them, and there really is no downtime. And then really educating the staff around them. Like I said early on, it's a team effort, and the team has to support the team. And often we will find that nurses will go and say, hey, can you help me with this? I have this. Can you help me with this? Can you cover me? I'm going to go on break. Those kinds of efforts pull these nursing staff and the clinical staff away from this role. And we really want to avoid burnout. How can we prevent burnout? What does burnout look like? Does the staff know how to recognize burnout when they're no longer wanting and desiring to talk to the patients? What do we need to do moving forward? And then do not misunderstand that ROI, and I cannot reiterate this enough, especially with our finance folks, it's not just a dollar, it's everything else. It reduces those avoidable readmissions and ER visits. We had one hospital that started the CCM program by tracking their familiar faces in their ER that they've seen often, and they had a 50% reduction in ER visits by 20 of the 50 patients that they were working with right off the get-go. So unreal, the changes. Looking at reducing our errors and mistake proofing, our discharge process, making sure that the patients have all of the necessary information, both printed and verbal, and they validate that, through the repeat back process. Impacting shared savings if you're part of an ACO. Our patient satisfaction, both on the hospital and the clinic side, and the ER side, and the outpatient side, no matter where you're measuring your satisfaction, we're getting it, we're capturing it. Our providers are engaged, they're happier, they feel their patients are being taken care of. Our staff are engaged, they feel the autonomy to work to the full scope of their licensure, and they can do more, and they can give more back to their patients, and they have the time to do that. And it really increases our market share. Again, going back to word of mouth, we all know what that looks like. So there are some ways, when we start looking at our enrollment process, what are we doing? How can we make this better? We learned kind of in the front end of this, cold calling was not the right thing to do. We were calling these patients kind of out of the blue and said, hey, what about this program? We'd love to get you. And they hear it as a sales pitch, you just want my money. So again, we have to look at how can we, provide some information to them without making it feel salesy and required that they must do it. We were looking at our Medicare patient list. They were inefficient. There was extra work entitled to everyone to create those lists. And, not everybody is going to be an appropriate patient for this. We created a list one time, and probably half of them were nursing home patients, and they really didn't fit the mold of a CCM program. Care coordination only is very slow. You have to embed it in other sources as well. We can't just do a care coordinator only does CCM. It's really, again, looking at your whole entire care management process. And then if we were to only target one source, there is a lot of limited or missing enrollees. We're not capturing the appropriate patient, right patient, right time, and that's what we want to get to. So we want to build our CCM program. And so what do we really need? We know we have to outline that process. We know we need to really frame it. And every clinic is its own individual process. And I can't stress that enough. While there are so many cookie cutter ones out there, and there's a lot of really good tools, each clinic is a little different. And there's some of those little nuances that are different in every practice and practice model that we have. So our hospital staff, looking at how do we communicate with them, our frequent flyers, our familiar faces, how does staff identify these patients? How do they communicate this to our care coordinator, care manager? How do we look at our referrals with our discharges? Who manages that? Who communicates it back to the primary care provider? Do we have a primary care provider associated with each patient? Are they taking new patients? Can we assist in that process? And then our clinical and staff and providers, what is it that they understand? Do they know our high needs patients? What do they see as a need? What can they identify and discuss during those visits, to start the, just to start the process. And we can tease it out of our patients. This day we're coming in for blood pressure management, and 2 weeks later they have to come in for a blood pressure check, that's a great way to start looking at that. Our annual well visits, hands down, is probably one of the best ways to capture patients. Bring them in for their annual well visit. It's free. You get one-on-one time with a nurse practitioner, a provider, a nurse, and they really help you to create that prevention plan, and goal setting. And we can build this right into that entire process. So when we start looking at our claims data, and I'm not going to talk a lot about claims, but I do want to touch on this because this one is a key point that we find in all of our clinics that are doing this, is all 3 dates must match. I cannot stress that enough, and your billers will get this immediately if you are not a biller and you've not seen this form before. So again, the service spans the entire month, but the month range will cause a denial. So you have to put, whatever date you choose, it has to be the same, in all 3 areas. And the dates cannot overlap with any other services. All right. So chronic care management, really is to achieve that overall population health. This is what I push. I want all of our communities to become that provider of choice provider, that location. We want this as part of our population health delivery model. This is what we're doing. It's doing it for the right reasons, and really embracing the community needs and looking at those disease processes. There's multiple things that we have that we can put into our population health. Our transitional care management, TCM, chronic care management, CCM, our care coordination, our Medicare annual well visits. What are we doing to move this forward? And then really looking at that population health standardization. What does it look like? Our care coordination process, we're eliminating those care gaps, but we're also really creating that communication between all of our healthcare settings in doing that elimination of our care gaps. We're practicing our prevention measures. It's every patient, every time. We're embedding it into our daily routines and how we follow up with these patients. And then we also have care transitions that we're following up. They're discharged from the hospital. Hey, by the way, I see you haven't made your appointment yet. Can you make your appointment? Can I get you in? Can I get you scheduled? Can't get a ride? Let me look and see how we can assist you. Again, we start to look at all of those care transitions and assisting our patients to make sure their needs are met. We set up some services if needed, to look at further enhancing the patient needs to be successful, have small wins, that their needs are being heard, they're not going unnoticed anymore. And then really providing all of that education, and we're validating that they get it. It is not just giving them a bunch of information, and that whole verbal diarrhea of what we do as healthcare providers. It's really making sure that they're not just nodding, signing on the line to get out of there. They're saying, hey, I have questions. Help me understand this. Here's what I understand you're telling me. Start to look at it on a different level. So providers and care managers, they really need to embed these into their daily activity. And it really does achieve some of those positive outcomes, and it's not just CCM and TCM, it is the entire way we practice, and we're giving the patients our devoted time, and we're saying, hey, we have these extra resources. I notice you have, your blood pressure has been a little wonky lately. I would love to get you part of this, so that this staff member can assist you each month moving forward and really improve those patient satisfaction, staff satisfaction, provider satisfaction. It's adherence to the recommended therapies, making sure the patients are successful. Yes, I went and got my prescriptions filled. No, I didn't because I couldn't afford them. I couldn't get to the pharmacy. What can we do to help that? Improve the clinician efficiency of recognition of patient needs, and making sure that we can enhance that communication pattern. We're looking at trying to reduce our hospitalizations, reduce our ER visits. We really want to enable some telephonic condition monitoring, maybe with some of our congestive hearts or our AFibs, our COPDs, looking at scales at home, blood pressure cuffs at home. Do they have good blood sugar glucose monitor? Are they measuring their weight? Do they understand what weight increase looks like? Even if it's 2 pounds, what does that look like? Looking at our medication monitoring. They took their pills every day. Yeah, again, there's some tracker tools that we can do out there on our phones that can assist in this if we really think it's necessary. But in most aspects, we find that if a patient feels like they're accountable to something, they'll do it. Yeah, I took my pill. Click, I hit the button. And it gives them that sense of achievement that I am making strides to do the right things, right time for me. And again, owning their self-management skills. And then we have our entire social determinants of health. And I thought this was a really interesting statistics that social determinants are why we spend about $1.7 trillion in healthcare on just 5% of our population. That's a lot of money. We could all use that money in our own communities. The efforts are being focused on medical, and they really need to be focused and shifted to the socioeconomic and behavioral aspects of what our patients are doing. So we build our successful framework. We've kind of got it all lined out. We're looking at internal and external resources and really starting to look at, okay, what other education do we need? Our nursing staff and clinician staff, are we doing motivational interviewing? Are we asking the right questions to pull those answers out of our patients? I will never forget my mother telling me when my brother went off to college, and she's like, I have to ask the right questions or I won't get an answer. I have to ask specific things, and sometimes I only get yes, no answers until I really force him to give me more than 3 words. And so again, are we, looking at our internal and external processes to capture the entire piece of information that we need? And then, making sure everyone is sharing and embracing the same visions and initiatives. Our value is offered, obtained with healthier populations. And we start to see this as we transition out, looking at our shared system members, and that communication pathway of how we're sharing this information for patient success. So when I go to the cardiologist, I know he is giving a report back to my primary care provider, and I know I'm going to be successful because they are communicating with each other. And we really are listening to our patients and hearing what matters most to them, and helping them to be successful. We want to, again, go back to our mandatory screenings and recommending testings. Embed it in your process. Where is the information at now? How are you ensuring you can capture that information? Do you have analytics or informatics on board that can really look at how do I drill this down in my EMR system? Can I make it a do not pass go until, that hard stop in the EMR that you must answer before you move to the next question or the next screen in the system? And it's the full lifespan of care, all the way through to palliative care. And how are we really looking at our patients during that palliative care time? And what can we do to assist them in, as much as I hate to say it, dying gracefully, and making sure that their needs are met, depending on if they're, aware enough. So a few review tips just to kind of wrap this all up. It is a system-wide change. Be sure you're ready for change. Again, look at some small ways to do some tests of change to get there. Look at your workflow, current jobs, who does what, not just who does what based on their job description, but what else are they doing? And, is it a good practice, bad practice, and who is it helping or not helping? And then again, start looking at your community. What's going to work for your community to transform that community into a more healthier community? What needs do you have? What kinds of gap analysis tools do you have that, that you can help prepare the community for these changes, and help you slowly embed these processes and these small increments over time into the community. Look at your community health needs assessments. Our EMRs don't always support our population health efforts. So we have to really look at how can we make sure that our EMRs are meeting our needs. Are we seeing this information with every patient every time in their records? And then utilizing our data, celebrate those small wins of success. That demonstrates to staff that, hey, we're listening, we're paying attention. This is what we need to do, and yay us, look at where we went. We only got 1 patient, but by golly, we got 1 patient. That sometimes can be a huge hurdle depending on that last month and what was entailed in the staffing. And then start to begin expanding that vision. And this is where, this isn't going to be in that right up front, plan, vision, mission, where we're going. This is really looking at, 6 months from now, we're going to start adding in some of these pieces as a potential, any behavioral, psychosocial care. Our patient-centered medical home, do we want to achieve that? Do we want to pursue that? Our community health worker programs, so what kinds do we have? Are they successful? How can we change this? And then looking at our palliative care, our nursing home rounds, what can we do differently? But overall, it's truly staying persistent, and your patients will thank you, your family members will thank you, your community will thank you. And, the Angieism that I'm always sharing is, you're truly becoming that provider of choice. And it's reflected in your surveys, your data analysis, that patient feedback, patient engagement, your physician engagement, your staff engagement. It's reflected back in what you are doing on a day-to-day basis. So thank you very much. It is straight up 3 o'clock. We have, some time to answer any questions. I haven't seen any come through on the chat box yet, but Jake may have seen some come through if at all possible.
I've just got requests to send slides. So okay. Nothing in the chat. If anyone has questions, you can go ahead and unmute your phones and ask away.
Hi, my name's Emily, and I do the chronic care management program here in Hallettsville at Lavaca Family Health Clinic. And I was going to see if you could go back to, there was a code, I thought you said we're an RHC. It was 99491. It's for 30 minutes or more. I wasn't sure if that was.
That is a new code, and I don't get into the codes too much. But I know the slides you're talking about. I really try to avoid the billing. And please bear with me. Close your eyes, guys, so you don't have a seizure here as I go backwards. And I know the code you're talking about.
Yes, because all I bill, I do everything. I'm the coordinator. I do my own billing for the program, everything. And so most of these patients that I have are very chronic patients. So I spend over 30 minutes with majority of them. So I was just going to reference that, and I'll bring it to our administration.
Yep, there you go. 99491, RHC practitioner, provided CCM, 30 minutes or more of CCM services.
Okay, perfect. I will ask them about it.
Yes, please do. And I don't know if you're on the NARC listserv. It's a free listserv, the National Association of RHCs. If you go to their website, you can get on for free. And we can ask if anybody has been successful at receiving further payment from this.
Yeah,
okay, perfect. Thank you so much.
No, I need to. Yeah, I haven't got to yet. Okay.
Other questions? All right, I see one in the chat box. 3 visits needing to be with the same PCP. What does the provider work as a team and/or? The PCP is on vacation off when the patient needs to be seen for a routine visit. If that is your standard practice, that they work as a team, it's okay. That you have those kind of scheduled 3 visits out. It's your normal practice is what you really want to embed. So. Perfect. Anybody else have any questions? Was this helpful? Again, just looking at, did this kind of give you that big high level? It's not the down and dirty. We do have some down and dirty things that we can share with you if you like. Again, my contact information is there. If you're looking for something very specific. So thank you, Kelly. So
will you jump to that last slide, Angie, where your contact info is?
Maybe. Sorry, guys. There's no easy way to do this on here. Look down, look away.
Just to go back again. we'll be sending this out, the recording out as soon as the file needs to compress, and then we'll send it out to everyone. And then I know I've got a few people here in the chat box that wanted slides. If anyone else wants slides, that's no problem. Probably the easiest way would be to email me. And my email is right here, Jake Hansen, jake@mysurveysolutions.com. Just let me know you'd like the slides and I can send them over to you.
And if there's any other education you guys would like to have, throw it in the chat box for us. Let us know, hey, I want some education on this. I want further on this. Let us know. We're here to help you.
I don't see any more questions, Angie.
All right.
I will, if other questions come through, if they come to me, I'll forward them along to you. And then, like I said, guys, if anyone would like the slides, please shoot me an email. I'll make sure you have them. And then we have a webinar coming up in September. It may not be for this crowd specifically, but you may have some people in your organization interested. We have special guests coming from Texas to chat about a brand new cleaning solution, actually, for hospital rooms, clean rooms, surgery, any of that stuff. It's really, really cool. You can actually drink the stuff if you want, but it kills everything. So that will be on in September. You can sign up at mysurveysolutions.com. We'll send email invites out as well. But everyone, thanks for your time today. Angie, thank you so much. And that concludes our webinar. Everyone have a wonderful day.
Bye all.